Hello and welcome to our introductory videos on the ECG. Now, today we are looking at the ECG paper, and when you pick the ECG paper, the first thing we must look, or the things we must see on the ECG paper, is that each small square represents 0.04 seconds in duration and 0.1 millivolt in amplitude. How do we come by this? As we know, the standard speed with which the ECG runs is 25 millimeters per second. And so if 25 millimeters per second is the speed, and we know that each small square from here to here is also 1 millimeter, then we divide 1 millimeter by 25 millimeters per second and we are going to get 0.04 seconds. Why is this important? This is important because we use this when we are counting small boxes for intervals. For example, when we are calculating the PR interval, where we multiply the number of small boxes by 0.04 to get the duration with which the PR interval or the PR interval as we want, then this calculation becomes very important for us to know. Another thing that we need to know over here is, since the whole of this small box is 0.04 seconds, we have 5 small boxes in one big box, and so we easily multiply the 0.04 seconds by 5 and we are going to get 0.2 seconds. Why is this also very important? It is very important because we use this to estimate the heart rate, so that the number of boxes, the number of big boxes which we count between one hour and the other hour will help us determine the heart rate of this patient. Now, the amplitude also, which is measured from this point to this point, is also 1 millimeter or 0.1 millivolts. And since we have 5 boxes in each one big box, we multiply 0.1 millivolt by 5 and we are going to get 0.5 millivolt or 5 millimeters. Now, the horizontal measurements determine the heart rate, as I've talked about earlier on. Sometimes also we use the number of boxes which we count within 3 seconds as well as within 6 seconds to help us to determine the heart rate of the patient. For example, if we have 15 large boxes, it will be equal to 3 seconds. And if we have 30 large boxes, it will be equal to 6 seconds. This is going to help us to determine the heart rate. We shall see it very soon that on top of the ECG paper and sometimes below at the bottom of the ECG printout, there are often vertical markings which represent the 1, the 3 as well as the 6 seconds interval. As you can see over here, this is going to be our 1 second, the 3 seconds and also the 6 seconds interval. And so it helps us when we are determining the heart rate of the patient. Now, as I said earlier on, each one big box over here like this has 5 small boxes and it's equal to 0.2 seconds, and the amplitude is also 0.5 millivolts. The next thing I want us to know on the ECG are the leads of the ECG. Anytime you pick the ECG, you see some writings on it. What do they stand for? The standard ECG has 12 leads. And in order for us to, accurately interpret the 12-lead EKG, we must understand the electrical activity of the heart, including the direction in which the impulses flow from one part of the heart to the other part of the heart. It is also very important for us to know that these 12-lead, ECG, or these 12 leads pick impulses from different parts of the heart as they travel through the heart. And so it's very important that we know what they stand for. Now, we have 6 of the leads which are considered limb leads. They are limb leads because they are placed on the arms and the leg of the individual. The other leads are considered precordial leads or chest leads because they are placed on the chest or the precordium of the individual. Now, let's pick the first 6 limb leads. These are standard lead 1, lead 2, lead 3, AVL, AVR, as well as AVF. The letter A stands for augmented, V is for vector, and so we have augmented vector left, augmented vector right, as well as augmented vector foot. Now, we call them augmented because they are calculated as a combination of standard lead 1, lead 2, and also standard lead 3. They all come together to give us information, from specific parts of the heart. They are also placed in the frontal, plane. What this means is they measure electrical activity from the frontal plane. Frontal plane here means that the patient is in anatomical position facing you. Therefore, the patient's left is on your right side. Now, the chest leads or the 6 precordial leads are also called V1, V2, V3, V4, V5, and V6. And these chest leads detect electrical impulses from the horizontal plane across the heart, and so it gives us a different view of the heart and allow us to detect certain abnormalities such as arrhythmias, which are unable to be detected, from the frontal angles. Now, as you can see on this slide, it is important for us to understand which leads represent which part of the heart. And so the standard lead 2, lead 3, and AVF represent the inferior part of the heart, or they give us information of the inferior part of the heart, specifically the right ventricle of the heart. Precordial leads V1 and V2 give us information from the septum of the heart. Also, V3, V4 will give us information from the anterior portion of the heart. Then standard lead 1, AVL, as well as precordial leads 5 and 6 will give us information, from the lateral sides of the heart. And as I've written over here, I see all leads. This is just to help you remember, the view of the heart and the leads that, gives the information. Now, more on the leads. It is so important that when there is any pathology of the heart, we are going to see, changes in these leads, so that if there is any abnormality or if there is any pathology such as myocardial infarction of the right ventricle, we are going to see ECG changes on standard lead 2, lead 3, as well as AVF, and it will even give us information as to which coronary artery is involved, and in this case we are going to find the right coronary artery. Likewise, when we have ECG changes in precordial leads V1 and V2, it gives us information that there are pathologies in the septum of the heart, and also the coronary artery which will be involved over here, maybe the left anterior descending coronary artery, or the LAD. And also, if you find any ECG changes on precordial leads V3 and V4, then we are talking about the anterior portion of the heart, pathologies of the anterior portion of the heart, as well as the left anterior descending coronary artery. And standard lead 1, AVL, as well as precordial leads V5 and V6 will give us further information as to where the pathology is coming from, and also it will indicate that the circumflex artery is also involved in this pathology. Now, how do we place the leads, the chest leads? We do it systematically, and so we first place the V1 on the 4th intercostal space at the right sternal border over here. Then just opposite to it, also 4th intercostal space, left sternal border, we place the lead 2. or the V2. Then we come to the mid-clavicular line and place standard, or we place V4 in the fifth intercostal space. Now, between V2 and V4, we place the V3. Then, in the same plane as V4, we place the V5 in the anterior axillary line. Then we place V6 in the mid axillary line, as you can see beautifully over here. And also on this diagram, as you can see, we've put together all the limb leads as well as the precordial leads, and they are giving us the general overview of the flow of impulses from the sinoatrial node to the rest of the heart. Now, as you can see, we have standard lead 1, lead 2, lead 3, as well as the augmented leads AVR, AVL, and also AVF. And you can see the chest leads also line up over here. They give us information as to the electrical activity of the heart. And if there is any pathology, we are going to find it on the ECG. So this is a rhythm strip of the ECG. And as you can see, we have our standard lead 1 over here. We also have our standard lead 2 over here, then lead 3, then our augmented leads AVR, AVL, and AVF, then our precordial leads running from V1 to V6 over here. Now, an important thing that I want to draw your attention to is the calibration spike. When we say the calibration spike, this is what we refer to as the calibration spike. This diagram over here, you find it on all ECGs. And this calibration spike tells us two main things: the speed of the paper and the standard amplitude of the ECG. And the normal calibration spike must be 10 millimeters tall, as we've seen before. Each big box over here is 0.5 millivolts, and so the normal calibration spike must be 1 millivolt, so it must be two big boxes in the vertical direction. So we have 1 millivolt or 10 millimeters. The other most important thing we must know is the speed over here. As I've said earlier on, this is the standard speed, 25 millimeters per second. And anytime you pick the ECG paper, you must look for the speed before you can determine even the heart rate of the patient. This is very, very important thing that we must know. For the frequency, we shall talk about it in a different tutorial. And so what have we learned so far? We've learned that each small square is 1 millimeter, and the duration is 0.04 seconds. And in amplitude, we have 1 millimeter or 0.1 millivolts. And since we have 5 small squares in one big square, we multiply 0.04 by 5 to get 0.20 seconds. And I said this will help us when we are determining the heart rate of the patient. And this amplitude will also tell us the amplitude of the waves as we measure them. Then also we learned that the leads gives us information to which part of the heart there is a pathology. And so standard lead 2, lead 3, and AVF will give us information from the inferior part of the heart. From the septum, we are going to look at V1 and V2. Anteriorly, we are going to look at V3 and V4. And laterally, we are going to look at standard lead 1, AVL, precordial lead 5, as well as precordial lead 6. Thank you very much for your time.